Hello, and welcome to the November JDRF Research Information Volunteer Call on Disease-Modifying Therapies for Type 1 Diabetes, Part 1. Today's speakers are Cassandra Bazile, Ph.D., and Josh Vieth, Ph.D.
Hello, everybody. Josh Vieth here, and I'm excited to join you for this RIV call on disease-modifying therapies. It's a great time to join you because it is November, which means it's National Diabetes Awareness Month. And you can, in a number of ways, hear about all the ways that JDRF is moving the search for a cure forward through all of our social media and some of our blog outposts. So keep an eye out for those. There's a lot of exciting information and material coming your way. In keeping that with that theme, we're going to today focus on how the disease-modifying therapy portfolio is moving our research strategy forward. And we're going to focus on this in three ways. First, how JDRF-funded active clinical trials are moving the field forward overall. Second, how JDRF is investing in improving future clinical trials to build even greater momentum moving forward. And third, how we're strategically funding new projects to fill our gaps in knowledge to bring next generations forward in the next line of disease-modifying therapies. Now, you have all seen the research pipeline before, but it's important that we start here because if we talk about moving forward, this is how we do it. It starts on the left side with discovery research and then translational development. So, we fund research. We advocate for government funding of research. We invest alongside for-profit funders in T1D products, and we work to advance clinical trials. And all this is part of our T1D therapy development section of the pipeline. This is where the research happens. This is where the ideas are turned into products that eventually go into clinical testing. Next stages, we talk about regulatory approval. And this is where we improve the prospects for regulatory approval by using our team that's based in Washington, D.C., who also oversees our healthcare coverage and our ability to increase coverage, affordability, and provide patient access and choice. And then finally, we work toward clinical adoption, supporting the continuing healthcare provider education so that clinicians know what therapies and trials are available for their patients, and educating the community about the trials that are available and what people are eligible for in their area. And this is the great work done by the clinical trial education team put together by Anastasia. All of this leading to better outcomes and then cycling through to the next generation of type 1 diabetes therapies. And all of this, the entire pipeline, is an integral portion of our mission and our strategy. When we focus in on our research priorities, there's a number of areas that these fall into. If you look at the top row here, we have global universal screening, disease-modifying therapies, and cell therapies. Together, these three make up what we call the CURES program, or the CURES research program. Under global universal screening, we figure out ways and we investigate ways to identify people at risk of developing type 1 diabetes early before they develop disease. We know that 85% of people diagnosed with type 1 diabetes do not have a familial relationship or a familial connection to the disease, meaning that we have to find those at risk beyond just testing relatives of those currently identified as having T1D. For disease-modifying therapies, we focus on rebalancing the immune system and supporting beta cell health and regeneration. And finally, under cell therapies, we look to develop cell therapy products or beta cell sources, implantation techniques, and then working to provide or restore insulin independence for those in stage 3 or beyond type 1 diabetes. We also have an improving lives portfolio that focuses on devices and technologies for improving glycemic control, psychosocial aspects related to the burden of living with the type 1 diabetes, as well as therapies for long-term complications. Finally, we work at the training of researchers and clinicians. And this is really tied into our strategy of identifying the best and brightest, to bringing those investigators into the field and helping them succeed as the next generation of leaders in T1D research. Today, however, we are going to focus in on this disease-modifying therapies portfolio, and we're going to talk about it. We're going to begin talking through some of the the projects and research in the portfolio today, and then we'll finish it next month with myself and Jay in the December edition. So simply, disease-modifying therapies are therapies that include treatments that both control the autoimmunity and preserve or regrow beta cells. We're accelerating the development of these therapies into clinical testing and eventually regulatory approval and access. And it really has two sides: immunotherapies and beta cell therapies. So under immunotherapies, we ask the question, how do we turn off the autoimmune attack on beta cells? Under beta cell therapies, we ask, how do we preserve and support functional beta cell mass? For today, we're going to be focusing in on the immunotherapies section of the portfolio, and we'll talk about beta cell therapies next month. If we're talking about immunotherapies, we have to talk about the immune system. And I've presented this a little bit before, but I'm going to briefly give some background before we jump into the projects. The primary goal of the immune system is simply to tell yourself from not yourself. It's the ability to recognize where something is a threat or whether it's part of your natural body or one of your own cells. And you have to maintain a balance here because you need to provide enough surveillance and enough activity to identify and eliminate any potential threats. But you have to refrain from being so active or having the immune system be so active that it begins to recognize and attack your own cells. And when this overactivity, when this recognition and attack of your own cells occurs, this is autoimmunity. And the inability for the immune system to properly determine between self and non-self is the basis and what can lead to the development of autoimmune diseases such as type 1 diabetes, which I'll explain a little bit more in the next slide. There are a large number of cells and processes involved in the immune response and in autoimmunity, but if we break it down simply for the purposes of today, we can look closely within an islet and we see a beta cell, and the immune system can interact. Once the immune cells are able to infiltrate into the islet, they can interact with the beta cell in a number of ways. One of these ways is they can pick up antigens from the beta cell or little pieces of beta cell. An antigen is just a word that describes anything your immune system can recognize. Now, this antigen can be recognized by B cells, which activate and then produce antibodies. Since those antibodies are against your own body, they're called autoantibodies, which are the autoantibodies we screen for when we're looking for people at risk of developing type 1 diabetes. These antigens can also be picked up by antigen-presenting cells, such as dendritic cells, which then show them to T cells. Now, when a T cell is activated by this antigen, they attack what they recognize. So they will go, and this attack of the T cells on the beta cell is the basis for the autoimmunity and the loss of beta cells in type 1 diabetes. Finally, there's another cell, a Treg or T regulatory cell, which is like a T cell, but instead of attacking, it actually releases chemical signals that cause the rest of the immune system to calm down. So really, this is all about balance. And our strategy, therefore, is based upon this biology of disease. Under the immunotherapy section of the disease-modifying therapy portfolio, we seek to disable autoreactivity. How do we turn off the T cell attack on beta cells or the B cell response to beta cells? This has been done in a number of trials and approaches. Most recently, we've heard about teplizumab, but also rituximab, baricitinib, abatacept, and elevacet are all pharmaceutical assets that are focused on disabling this autoreactive recognition by the immune system. Another approach we can take is enhancing regulation. This means supporting the function of these T regulatory cells and allowing them to better control the immune cells around them. This is done through a number of ways by increasing the number of Tregs, and this has been attempted before through Treg therapy, which you guys have heard about, IL-2 therapy. But one of the things we're going to talk today in one of the projects is tolerization therapy. How do we specifically activate these cells and tolerize the immune system? So basically that means how do we promote the recognition of these antigens by Tregs over the other cells of the immune system? And the last section is disrupting inflammation. As these immune cells activate, they cause a lot of local inflammation and tissue damage, which releases more of these antigens for the immune system to recognize from the beta cells. So how can we decrease the amount of inflammation occurring, particularly in the pancreas? We're looking at a number of ways to do this, and this includes trials going on with ustekinumab, which acts on IL-12 and IL-23, which are two of the mediators of inflammation in the body, as well as some strategies looking toward TNF-alpha. Now, understanding how the disease develops is important as we talk about the stages of type 1 diabetes. Now, we've all seen the normal staging graph that we show, but we put in because we're talking about immunotherapies today, we decided to show it a little bit with what's going on behind the scenes to set up some of the projects we want to talk about and what they mean for why we're targeting certain stages of disease. The most important thing to know about this slide is that recognition of a beta cell by the immune system happens very early on. This happens long before what we call stage 1. It happens long before anybody goes and gets tested. This happens very early, and you have the recognition of a beta cell antigen by a cell in the immune system, and that sets off the immune reaction, which can be slow building, but it sets off a growing immune response. Now, when we talk about people in stage 1 to disease, we say they have 2 autoantibodies. So there's 2 autoantibodies, 2 B cell created antibodies that are floating through their system that can be detected in their peripheral blood that are specific to beta cell antigens. This means that there is definitely an immune response to the beta cells going on, but it hasn't escalated to the point where you've lost functional beta cells or you've lost insulin production. You're still producing insulin at full capacity. When we talk about people in stage 2, these are people that have 2 or more autoantibodies, plus they start to have some abnormal blood sugar levels. This means that autoimmune reaction has ramped up. You've started to have some immune infiltration, maybe some T cells and dendritic cells within the islets, and you start to lose some of those or a few of those functional beta cells. This is what leads to the abnormal blood sugar and slight decrease in insulin production. Now, stage 3 is when people are diagnosed based upon their HbA1c, and this is where insulin dependence starts. You still have some insulin secretion, but you've lost a majority of or a good portion of your functional beta cell mass. And you can see that here. We've had more immune cells infiltrate into the islet. We've lost more of our functional insulin-producing beta cells as that disease state wraps up. And finally, in established type 1 diabetes, you have loss of that functional beta cell component. You've lost the ability of these cells to produce insulin, and you are no longer producing your own insulin at any level. Before we talk about some of the exciting research that's moving along, we have to talk about one of the successes that from the last year, which is the approval of Tzield in stage 2. So along these, as we're talking about disease-modifying therapies, Tzield works by targeting and altering T cells. And as you know, T cells, as I showed, play a major role in T1D development. They're the cells that are activated and actually attack the beta cells. Now, Tzield was approved last November for people ages 8+ with stage 2 type 1 diabetes. And it's been shown to be able to delay the onset of type 1 diabetes for nearly 3 years on average. But excitingly, just about a week and a half ago, the PROTECT trial reported out. And the PROTECT trial demonstrated that Tzield preserves beta cell function and can slow the loss of beta cells in children and adolescents with recent onset or stage 3 type 1 diabetes. And we're very excited about what this means for the field. It means that the teplizumab that is approved for stage 2 has a chance now of perhaps moving forward with stage 3. And we're waiting to hear from Sanofi on their plans and to see this move forward. And importantly, what it means is that teplizumab joins a number of disease-modifying therapies that have shown efficacy in stage 3 or new onset disease. This includes abatacept, golimumab, verapamil, teplizumab. All showed some preservation of C-peptide compared to placebo. And while this is only for while the patients receive the drug, we haven't yet been able to, or we haven't had the data on the long-term efficacy. We know that while patients are on drug, we can preserve C-peptide, and there's a number of strategies to do so. And this is important as we start to think about which patients can benefit from which therapies, and as we start to build combinations for providing lasting or more lasting responses and rebalancing of the immune system. So now I'm going to turn it over to my colleague, Dr. Cassandra Bazile, who is going to talk through some of the exciting projects that are going on in the portfolio.
Thank you, Josh, for taking us through the disease-modifying therapy strategy. Hi, everyone. My name is Cassandra Bazile, and I'm excited to talk to you about exciting projects that are happening in the space. I'll first start off with JDRF-funded active clinical trials that are moving the field forward. As Josh just explained, T1D is a complex disease, and the factors that initiate disease are unknown. This project explored the role of viruses called enteroviruses in the development of T1D, and for the first time tested an antiviral drug in children with new onset disease. Results from this clinical study showed that those who received the antiviral drug maintained higher levels of insulin production compared to those who did not take the drug. This demonstrates that treatment with antivirals can slow progression of T1D, moving the field forward towards an effective treatment. The results are currently published in Nature Medicine. In this last clinical study, Swedish investigators will test the use of Diamyd in a phase 3 clinical trial. Diamyd is an antigen-specific therapy directed towards a GAD autoantigen that works to stop the autoimmune destruction of beta cells. The study is called Diagone-3 and will include approximately 300 adolescents and young adults ages 12 to 29 with recently diagnosed type 1 diabetes. To be eligible, participants must have the HLA DR3-DQ2 gene, a genetic risk factor for T1D. This is important because this study is the first to use previously collected samples to determine patients that are likely to respond. They're recruiting patients in 50 sites in the US and Europe. And if this is successful, it'll propel the field towards a highly effective therapy for T1D. In this section, I'll talk about projects that JDRF is supporting to improve future clinical trials to build even greater momentum moving forward. Despite several recent successes, product development in T1D remains costly, lengthy, and high risk for product developers. To ensure new products become available for people at risk or currently living with T1D, the community must collaborate to improve the efficacy and likelihood of successful new products for T1D. The overall goal of TOMI was to leverage the clinical expertise of academic clinical researchers from around the globe to seek regulatory endorsement of a clinical trial simulation tool that's capable of de-risking decision-making and optimizing the design of clinical trials. The report of the TOMI project was recently published and showed that C-peptide can be used as a surrogate endpoint for disease-modifying therapies. This result is significant and an important accelerator for disease-modifying therapies moving forward. Another initiative that we're funding is the Australian T1D Immunotherapy Collaborative Consortium. The mission of this project is to accelerate development and delivery of T1D immunotherapies in Australia and New Zealand. This proposal will support a team of researchers from several Australian and New Zealand hospitals by providing people with T1D access to clinical trials of immunotherapy drugs, educating and training the next generation of endocrinologists, and helping consumers, JDRF, government, and other advocacy groups advocate for regulatory approval. And finally, this last initiative comes to us from Professor Colin Diane at Cardiff University. There's a critical need to detect what is happening to insulin-producing cells earlier in the disease process so that we can tell whether a treatment is effective or not. This study will test the use of a tool that more precisely measures beta cell function early in T1D using data from the oral glucose tolerance test. If successful, this tool will help us determine within 6 months whether a drug is slowing the disease process or if another therapy should be used. In this last section, I'll discuss how JDRF is strategically funding new projects to fill gaps in knowledge to bring next-generation therapies forward. One thing Josh talked about was finding therapies that have sustained rather than transient rebalance of the immune system. A way that we can do this is by testing combination therapies. Out of the many types of immune cells that are involved in T1D, B cells and Tregs play a crucial role in the process. While B cells enhance the autoimmune process, Tregs try to restrain it. This project will test the use of 2 drugs in combination. One of the agents will promote Tregs, while the other drug, BTK, a BTK inhibitor, will dampen B cell maturation and cause B cell depletion. In summary, this project will test the efficacy of combining therapies that enhance Tregs while depleting B cells to stop or significantly delay T1D progression. This next project is an excellent example of how we're using knowledge from other fields to help with T1D. We don't fully understand why T cells in autoimmunity don't become exhausted like they do in other instances, such as cancer or prolonged infection. Dr. Thomas Kay has created a team of 11 experts ranging from T1D biology to drug development to explore this question and to develop a therapeutic agent for the use of T cell exhaustion to shut down T cells driving disease in T1D. This project was developed under the Cures Collaborative RFA with the goal of using combined expertise and resources to drive development from discovery research all the way to a therapeutic agent to validate for human testing. And lastly, this next project comes from an investigator who is new to T1D. Dr. Andrea Scheidinger is a cancer immunologist who is now applying her knowledge from cancer biology to T1D to determine how autoreactive T cells are maintained in T1D. Dr. Scheidinger previously identified a subset of autoreactive T cells that express a protein that maintains stemness and self-renewal called TCF1. Shockingly, as few as 10 of these T cells can initiate disease in mice. This project will identify critical elements contributing to how TCF1 positive T cells arise and how they're sustained, with the goal of reprogramming these cells to prevent beta cell destruction. With that wraps up the section that highlights many projects moving the disease-modifying therapies field forward for a treatment for T1D. Josh will now give an overview of the portfolio.
Thank you, Cassie. To wrap things up today, I'm going to go through the disease-modifying therapy portfolio to give you a high-level look at some of the projects and where we're funding. Of the 420 grants that are active grants in the JDRF research portfolio, roughly 32%, or $117 million worth, fall under disease-modifying therapies, which means it's a substantial portion of the overall research portfolio. If we break these grants under the disease-modifying therapies portfolio down, you can see that they fall across all stages of research, from discovery to late clinical. In fact, if we take a look at this data another way, these numbers represent the number of projects under each priority area of disease-modifying therapies, as well as stages of development. And there's no need to get too far into these numbers other than to show that we are funding projects in each of the priority areas, from disabling autoreactivity, enhancing regulation, and deviating inflammatory processes that we've talked about today. Also, for beta cell survival and beta cell regeneration, we'll talk about next month, including combination therapies that tie these all together. In each of these cases, we're funding new discovery projects to find the next targets, the next assets. We're working on identified targets through early preclinical and late preclinical research to validate them and get them ready for human testing. And we have 11 clinical trials currently funded under the disease-modifying therapy portfolio, both in early clinical and late clinical development. Now, if we focus in on these clinical trials, you can see that they also span the breadth of our work. Some of these we talked about today. We talked about baricitinib and Diamid as 2 ongoing trials that we're excited to see the report out from. Baricitinib is currently a phase 2 trial, or Bandit, and Diamid is a phase 3 trial. The other phase 3 trial we're funding currently is Verapamil, the Clever extension, which we'll talk about next month as part of the beta cell survival portfolio. And then we have 3 combination approaches that are currently in clinical development under this portfolio. We have an intensive beta cell rescue using etanercept, an antiviral med, and fenofibrate. It's a phase 2. We have a combination approach looking at abatacept and nasal insulin. That's also phase 2 therapy. And then finally, the Vera T1D plus, which is teplizumab plus verapamil, which is a phase 2/3 study. And we'll be going into all of these studies in more detail in future IRVs, and we're excited to share these as they report out. Now, when we're talking about clinical trials, of course, we want to talk about how you can get involved. And one of those ways is letting your local community know about clinical trials that are available, or knowing which clinical trials you may be eligible for. 3 we're highlighting that are currently being run by TrialNet, and because they're part of TrialNet, are all funded by the Special Diabetes Program that JDRF is instrumental in getting the support for from Congress. The first one is Stop T1D, which is the TrialNet ATG prevention study. This is a prevention study, so it's in high-risk stage 2 individuals between the ages of 12 to 35 that's testing low-dose ATG. This acts on the T cell, so it's part of that disabling autoreactivity portion of our strategy. The next is Jackpot T1D, which is a trial looking at a combination of 2 JAK inhibitors in newly diagnosed individuals aged 12 to 35 years of age. And finally, T1D Relay, which combines 2 immunotherapies, rituximab and abatacept, in newly diagnosed individuals ages 8 to 45 years of age. Now, for more information or how to get involved or for any of these trials, you can go to www.jdrf.org/clinicaltrials, or you can very conveniently take a picture of this QR code, which will take you there, and you can bookmark it to continually check back. One of the new sections on that website is features trials section, which every month will highlight a new trial that's recruiting to keep everyone up to date on the latest information. And also, please, everyone, be sure to reach out to your local clinical trial education volunteers. That team is an amazing resource at the chapter level. So to summarize what we discussed in the first portion of the Disease Modifying Therapies RIV for this year, I hope we brought across the point that the JDRF Disease Modifying Therapies project is building upon recent successes with things like teplizumab, and we continue to maintain and develop a robust portfolio of immunotherapy research. And this is being done in a number of ways. We're funding active clinical trials that are taking big steps toward moving the field forward. We're investing in improving future clinical trials so that we can continue to gain momentum as we go into the next phase of testing. And finally, we're strategically funding new projects to fill gaps in knowledge and to bring the next generation therapies forward. And with that, we'll end the recording of this RIV, but we're looking forward to taking your questions during the live portion in a week or so. And as always, we thank you all for the work you do as research information volunteers. And on behalf of Cassandra and myself, it's truly a pleasure to be able to share information about the portfolio and the projects we're excited about. And we're looking forward to the discussion. Have a great day.